Okay, the next speaker is Cole Wayant from, no, I don't need to say where he's from, you can say that, on methodological and reporting, quality of systematic reviews, underpinning clinical practice guidelines.
Hello, it's an honor to be here. I am a dual degree medical PhD student in my first year of my PhD, so speaking here is a great honor, and I look forward to meeting many of you after this talk. I'm here today to talk about the methodological and reporting quality of systematic reviews that underpin clinical practice guidelines. This study was funded by the American Association of Colleges of Osteopathic Medicine. I made a mistake on the slide, it should say medicine instead of physicians. My co-author is my PI, Dr. Matt Vassar. So I'm a part of a greater research team that consists of members of different areas of expertise and different levels of education. Every team consists of at least 2 medical students, 2 residents or fellows, and at least 1 board-certified physician in the area that pertains to the study. All of us are recruited for the study and receive extensive training prior to the inception during the protocol development. We receive training in systematic review methodology, clinical practice guidelines, randomized control trials, as well as specialized review and training in items such as PRISMA and AMSTAR that we employed today. During the study, we use duplicate data extraction. Validation was performed daily between the reviewers, and weekly meetings were held for quality control. So the central question here was the methodological and reporting quality, or completeness of reporting, of systematic reviews that underpin clinical practice guidelines in key areas of medicine. The areas of medicine were identified based off the medical students' interests, and were pediatric obesity, opioid use disorder, and ST-elevated myocardial infarction, or STEMI. The first step was to search national guideline clearinghouses for relevant clinical practice guidelines. From them, we extracted the systematic reviews using a combination of title and abstract screen and full text search when necessary. And we scored the reviews using PRISMA for completeness of reporting and AMSTAR for methodological quality. So the number of guidelines identified varied. In pediatric obesity, we identified 27 guidelines, excluded 19, mostly on the basis of not being the correct patient population, not including children and adolescents, or being duplicates, such as if a new or revised version of a guideline being published, we excluded the old guideline to avoid duplicate quality scores being assigned. For opioid use disorder, we identified 25 guidelines, 8 of them were excluded, and 17 were included, with 57 systematic reviews total. Those were mostly due to duplicates. And for ST-elevated myocardial infarction, we identified 30 guidelines, of which only 4 were included, and these were mostly excluded on the basis of dealing with acute coronary syndrome non-specifically, or non-ST-elevated myocardial infarction. We wanted to look at STEMI specifically. So we want to know how these systematic reviews were used in the clinical practice guidelines. There were 150 total systematic reviews across 29 clinical practice guidelines. Only 8 of these clinical practice guidelines had recommendations associated with evidence grades. Of the 150 total systematic reviews, 308 total citations, there was about 38% that were used as direct evidence for a recommendation, with the remaining being used in the background narrative. Now to the quality scores. Pediatric obesity tended to be the lowest scoring in terms of the quality measures that we used. The 22 systematic reviews averaged about 17 out of 27 PRISMA items that they adhered to, and about 5 out of 11 AMSTAR items. For opioid use disorder and STEMI, the scores were similar for PRISMA. Each was about 21 out of 27 on average. Opioid use disorder performed the best in AMSTAR with approximately 9 out of 11 items adhered to, and STEMI approximately 6 out of 11 were adhered to. Then we wanted to look at common threads across the 3 areas of medicine. So I have here all the underreported items for each area. We defined an underreported item as an item that had less than 50% adherence across all the systematic reviews within that area of medicine. And if more than one area of medicine had an underreported item, we highlighted it in blue, and we'll discuss it on the next slide in more depth. So we can see reinforced here that pediatric obesity has the greatest number of underreported items, followed by STEMI, and then opioid use disorder. So The underreported items for completeness of reporting as measured by PRISMA. The first item was number 5, protocol and registration. We found very infrequently that these systematic reviews were registered. The search strategy was not adequately detailed often. This usually meant that they did not include at least one of their database searches in a supplemental file or in the body of the text. And the risk of bias across studies. The risk of bias was underreported across studies was underreported in pediatric obesity and opioid use disorder for 2 different reasons, we believe. In pediatric obesity, it was not included across studies because the individual studies themselves were not assessed for risk of bias. In the opioid use disorder, the individual studies were assessed, but these assessments were not included when combined into the results across studies. So same methodology for AMSTAR. The underreported items are in blue if it occurred in more than one area of medicine. Again, pediatric obesity is the lowest quality overall with the most number that were underreported, followed by STEMI and opioid use disorder. So the first 2 items, item 4 and item 5 with AMSTAR, are duplicate screening and extraction and included and excluded studies. We were unable to determine whether or not this was poor methods on behalf of a reviewer or poor reporting on behalf of a reviewer. Very commonly, the excluded studies were not listed either in a supplemental file or some online open database. The duplicate screening and extraction, we want to believe that this was occurring often, but it was not detailed well in the methods section. The quality of evidence in the conclusions is somewhat of an overlap from PRISMA, and the conflicts of interest are underreported in AMSTAR because AMSTAR requires the inclusion of the individual studies, the primary studies, randomized control trials, that their conflicts of interest and funding sources be detailed as well as the systematic review. So what's the significance of all of this? So we know that bias assessments and conflict of interest disclosures are safeguards from potentially flawed conclusions. It allows the peer reviewers, the editors, and the general readership to understand which forms of biases might be entering into the literature that can affect conclusions. We know that improperly reported methods tends to blind readers from assessing how comprehensive a review is, and that suboptimal methodological and reporting quality may negatively affect patient outcomes down the road when these systematic reviews are combined in the clinical practice guidelines that drive evidence-based practice. Only 8 of the clinical practice guidelines were graded, which may impair physicians when they seek to determine what high-quality recommendations to implement in daily practice. And all research stakeholders are accountable, and we really mean this. We mean that the reviewers, the guideline developers, the peer reviewers, the editors, and the general readership and the patients, we all stand to gain from higher quality systematic reviews, and we're all responsible to improve the quality and education of these reviews and reviewers. So with that, thank you, and I'd love to field any questions you have.
Thanks. Can I ask whether there's any guidance for clinical practice guideline groups about how to judge whether evidence in systematic reviews is reliable? Or should there be?
I believe there should be. I'm unsure of the way to go forward with this. If a systematic review does not adhere to PRISMA or AMSTAR or some quality score, are the guideline developers required to assess the systematic reviews themselves before including them? Another important point we saw was that we did include Cochrane and non-Cochrane reviews. It wasn't a central question to determine the quality of the reviews between Cochrane and non-Cochrane, and so perhaps guideline developers may, when they do see quality scores associated or a Cochrane review, may favor those when driving their recommendations.
Because you think there's a tendency for people who are not perhaps familiar with systematic reviews just to know that they are level 1 evidence and they're published in a good journal, therefore we can rely on it. Because that seems to be still a common attitude.
Right, and I know lots of areas of medicine do consider systematic reviews level 1A evidence, and so it's difficult for developers or guideline developers who are not aware of the differences between systematic reviews, that they're not all created equal, to treat them as such.
Yeah. Okay, I'm not seeing any anyone? Okay, I'll shame somebody into it.
Sorry about this. Vivian Bachelet from Chile again. Talk about waste. In my country, the government, the Ministry of Health, has commissioned dozens of systematic reviews. I've done some of them with my team in 2008, 2006, around those years. That's when we set up a policy to have clinical practice guidelines that would drive spending from government on a set given of disorders that would be covered completely, so universal coverage. I was really sorry to see that the systematic reviews that the Ministry of Health had commissioned to us were subsequently not used in the clinical guidelines that they had developed themselves with the societies, with the corresponding societies. And we were also sorry to see that the conflicts of interest were not being disclosed in those guidelines, and those guidelines were later the basis for the baskets of funding, of specific funding. So this is just to point out an experience from a non-first world country, and I think waste goes far beyond what you can see in the developed countries, and it's a really sorry situation.
Yes, that's a wonderful point.
Yes, please.
Oh, hello, Jennifer Ben from Sydney. This is a bit of a left field question. I guess what a lot of presentations are calling for is, they're highlighting increased responsibilities on all the stakeholders, including peer reviewers, but we all recognise that peer reviewers are often busy and having to do peer review really in extra time. And I guess something that I think about is ways of increasing the peer reviewer pool, which might include involving younger researchers in peer review more extensively. So I just wondered if you could give your perspective on that as somebody who is at an early stage of your own career.
Yeah, so I am, as I mentioned, a first-year PhD student. I've completed 2 years of medical school and have been researching essentially those entire 2 years leading up to my PhD. I have been invited to peer review, which I was surprised at, given my limited number of publications, but it was a great honor, and I know that a lot of my colleagues who are even not doing the PhD track are very well versed in this methodology and would be able to very well evaluate maybe a primary study or scoping reviews, some of those reviews that we get. I think that's a valuable resource that can be used that I would encourage people to use.
Okay, thanks. Over here, please.
I was wondering if you had any observations about Minority Report or controversial issues or equivocal or data that might lead in two directions, and how any of that was being dealt with, if that was something you came across in your searches.
Well, we didn't necessarily look at when the systematic reviews were conflicting and how guideline developers used conflicting systematic reviews. We didn't really look at that specifically. We did look at things such as, how many Cochrane reviews were available versus how many were included in the guideline. For pediatric obesity specifically, I believe it was only 3 out of 11. And so that might be, once again, when quality comes into account, that might be a deciding factor between two conflicting reviews. It might just be that it's a lower level of evidence, that future evidence might adjust the evidence grade given to that recommendation.
Mm-hmm. I just think it might be something worthy of highlighting. Certainly if the purpose of the guideline is for reimbursement, you don't want to muddy the waters for the policymakers, but on the other hand, if the guideline is meant to drive the science and the practice, I think that we should be seeing more highlighting of where there's areas of controversy and owning it, dealing with it, yeah.
Yes, that's a good point.
Okay, one here.
Michael Mullins, Washington University in St. Louis. I'm involved as an editor or associate editor in 2 journals and reviewed for probably a dozen journals in the last decade, only one of which has a dedicated statistics or methodology reviewer. Given that most journals that I've reviewed for, and probably many others, do not have a dedicated methodology reviewer, and implicitly we're placing the assurance that authors adhere to the guidelines on the shoulders of the peer reviewers, we probably have the obligation, I think, to give the reviewers the exact checklist applicable to that study design for systematic reviews or randomized trials and so forth, so that they're armed with a simple checklist that we're expecting the authors to adhere to, so that if we're going to give them that responsibility, we should give them that tool.
That's correct, and I would even go so far as to say that just requiring that a PRISMA checklist or an AMSTAR checklist be submitted with the manuscript might aid the reviewers in identifying, okay, this item isn't adhered to because it doesn't apply, and here's how the authors explain that, or here's the justification for, it might aid reviewers in answering some of their questions that they might have during the review.
Okay, yeah.
Hal Sox again from PCORI. This is an important topic because practice guidelines drive the policies that shape the way we practice medicine. So my question is maybe more of a comment than a question is, can we trace the problems with the systematic reviews, the ones you've identified, forward to see how they influence the real sharp point of this exercise, which is the conclusions of a practice guideline committee?
Right, and that's definitely possible. It wasn't something that we evaluated. We were just looking at the overall quality of the reviews, but it would be very easy to evaluate. This was a low quality review included in a recommendation that received level 1A evidence, and now that's the standard of care. If we adjust the quality based off certain issues that were lower quality of the review, would that change the evidence grade? Would it change clinical practice and decrease waste in clinical practice?
So it's an important problem, but I think the cause and effect
Correct.
of going from the systematic review to the outcome of the guidelines will be actually a methodologic challenge.
Yeah, and that's a difficulty that we came across, was how do we specifically link this to patient outcomes? So going forward is something we'll look at.
Thank you.
You're welcome.
Okay, thank you very much.